Well, good morning, everybody. We had a very interesting morning today with many subjects that hit into telemedicine. As we've seen, it's an important subject that we have gone through pretty well, and I think everybody's familiar right now with what's going on. In this session, we will have two speakers, and then we will end up with a debate to spice things up a little bit, and ended up with a nice discussion there. So we will start with Mr. Isa Almuradi. Mr. Isa is a graduate from Swansea University. He's completed a law degree there and joined us in King Hamad Hospital last year. And he is currently the head of the legal department. He will speak to us about the importance of our legal issues regarding telemedicine, as we have discussed, and Dr. Lina talked about the ethical and regulatory issues regarding the telemedicine. You would have legal issues coming in because this is like a usual clinic visit. So I will leave the floor for Mr. Isa. Please go ahead.
Thank you, Dr. Omar. Good morning, everyone. I hope my voice is clear enough. I'll be sharing my slides in a second. Just 1 second as I share my slides. Yes, good morning, everyone. In my presentation, I'll be talking about the legal consideration in regards to telemedicine. Unfortunately, as it's often the case, the technical and technology adaptation is a bit faster than the legal when it comes to issuing guidelines. Recently, the NHRA had released the telemedicine dispensing procedure, which only addresses one aspect of telemedicine, and that is in regards to e-prescription. However, due to COVID-19, we are now forced to go through telemedicine. In this presentation as well, the things that we'll be considering is e-consent, licensing, patient privacy, security, standard of care, and medical malpractice. The first question is, does telemedicine require consent? Yes, consent is a fundamental when it comes to any sort of a patient-doctor relationship. However, now that due to dependency on technology, it's going to be changed. The e-consent will be formulated. We still need to obtain e-consent. However, the question is there any guidelines for e-consent specifically? Currently, there isn't. However, we have to follow the standard guidelines, which addresses the traditional practice. Although, the traditional practice have a lot of terms that some of them might not be adaptable with technology. For example, the security measures were undertaken that we need to follow, such as we need a clause that specifies that a reasonable online security measures were undertaken for the use of telemedicine service. As I said earlier, because we are dependent on technology, information might get lost. So that's why you need a clause like that. However, the most important thing is a doctor has the right to request the patient of physical examination if required. As we are all aware, a doctor, any misdiagnosis will result in a malpractice in which a doctor will be held liable. A clause like that will not let the doctor be requesting the patient into having an answer. He can request the patient to come if he's uncertain, if he needs to do more diagnosis. Our next point is licensing. A matter of licensing is that should there be a minimum level of expertise before practicing telemedicine? In the USA, this is one of the biggest legal barriers because a practitioner in a certain state cannot provide telemedicine in another state in which he doesn't have a license at. For example, the following case. Dr. Shaikh is a Colorado licensed practitioner, prescribed fluoxetine over the internet to a patient in California without obtaining a license for practicing in California. Several weeks later, the patient was found dead by means of carbon monoxide poisoning, by which a detectable amount of fluoxetine and alcohol in his blood. Dr. Hexet was community charged. Now, you might be wondering, like, how would that apply in Bahrain? It won't, the concept behind, like, each state is not reluctant, is not because it's unsupportive of telemedicine, but because each state has its own standard of quality. Having another practitioner from a state to provide that might lower that bar. We could use that standard in which we can have a minimum standard of quality. If a doctor possesses to provide telemedicine service, he can go ahead and provide it. You might wonder, like, what kind of those set skills. There are many outside Bahrain dedicated tele practitioners that we could outsource as per the NHRA guidelines for expertise, and we can know what exactly are the skills required. However, bear in mind, this is just one aspect of why we advise to have a license to practice telemedicine, and that is in terms of skill-wise. Excuse me, Adi. Patient privacy. Does telemedicine affect the current concept of patient privacy? Before answering that, we have to ask, what is the current concept of patient privacy? Doctors are under two main obligations. Number one is maintaining records of patient information, such as consent forms, lab test, evaluation, reports. The other obligation is not to disclose that information. Regardless of whether it's telemedicine or another sort of medical practice, it is as well one of the fundamentals of establishing a patient-doctor relationship. You need to obtain and keep records of those. There are many laws that addresses that, such as the data protection law, which state that a doctor, it states that a patient information should not be shared, unless there are two exceptions, such as if you obtain a court order, you can share a patient information. And number two is if the vital information is beneficial for the public interest. It is kind of interesting to ask whether COVID-19 patient can apply as an exception, but that is at the end only the court can decide. Which brings us to the next point. Then, since we established that a doctor have to still maintain the patient records, even though it's going to be through a phone call away or video, we have to discuss what kind of security is he using. Security is fundamental requirement. However, several securities must be answered, such as what kind of encryption is he using for storing medical data, and what kind of encryption is used for transmitting medical information. As I stated earlier, part of issuing the license to practice telemedicine, not only we can look at the skill levels, we should ask ourselves, does he maintain the proper security? And which brings us back to what platform are we going to be using? That means is each clinic will be having its own website to provide telemedicine, or are we going to be using such as Skype, Zoom, or any sort of social media communication? And the standard of care. In regards to the standard of care, there are like two debatable questions. Would it be justifiable to provide less adequate care than the traditional standard practice due to the absence of physical examination? And some might argue that the doctor owe a patient a higher standard of care because the patient was not being physically examined. Now, this is purely an ethical question that could go both ways. But however, in terms of the law states that the practitioner doctor is still liable and will be held accountable if he did not follow the traditional standard of care, meaning regardless of whether it's telemedicine or not, you have to follow the standard practice of care. Which brings us why to, in the e-consent that we need to obtain, we need to have a safeguard clause for the doctor, in which if the doctor is not sure whether he properly diagnosed the patient, he can still call him in. A patient will still sign the e-consent, and the doctor can still have another diagnosis. Because as you're aware, some doctors might find another symptom that patient isn't feeling, and which could be the main cause of the problem. But however, when it comes to the e-consent, there is a bit things need to be determined exactly, such as when to obtain it. We have to follow to the, as I said, in regards to obtaining an e-consent, we have to follow the original NAHRA guidelines. NAHRA guidelines have only issued consent guidelines in regard to the physical presence of the patient. They have a lot type of consent, such as explicit, implied, explicit, implied, and they do have as well, which is a weird consent form, which is called consent for treatment. And basically, you have to sign this consent form in the admission, in the reception, before you see a doctor. As I read the policy, one of the most valid elements to having a valid consent is the opportunity of question and answer, in which a doctor discusses with the patient all the risks and any alternatives method of care before prescribing a medication or before beginning the treatment. But it's kind of, how come a patient has to sign that form before? It's like signing up for something you have not processed yet or you have not pursued yet. So yes, as I said, the standard of care, if a doctor, even though, as I said, because if the standard of care was not followed properly and the doctor did not follow the traditional practice, the same thing will apply, and that is medical malpractice cases will rise. There are no exceptions right now for telemedicine in regards to medical malpractice, but what are the current principles we follow for medical malpractice cases? Before we answer that, we have to ask, what is the origin? What was the first case that set up that principle? It's known as the Bolam test, in which, as you can see the facts, I'm going to briefly talk about them. A voluntary patient at mental health institution and agreed to undergo electroconvulsive therapy, but he was not given any muscle relaxants in his body, which restrained him from during the procedure, and he reacted violently. He suffered fractures in the hip, and he sued the hospital. The principle that was set back then in 1957 is still the same principle that is being followed today, and that is the court will have a specific committee, a group of an objective expertise of doctors in that same field, and based on their recommendation, we have to go if the standard of care has been followed. Which brings us back in Bahrain. Bahrain still follows the same process. Medical malpractice still falls under NHRA, and the NHRA currently has 4 committees, such as the practice of medicine and dentistry, profession of pharmacy, practice of the profession of nursing and obstetric, and practice and associate medical profession. Those are the 4 committees. Depending on the case, we'll decide which each committee should fall, and the penalties are kind of the same in each committee, which is warning, suspension up to a maximum of 1 year, and cancellation of the license. As the suggestion is, regardless of whether the method of care is different, the fundamentals has to be the same. You have to obtain consent. You have to keep the patient information, which is kind of tricky when you're dealing now with a phone call away of providing medical practice. And you have to store that information. And failure to do that, as I said, will result in medical malpractice. Thank you so much.
Thank you, Ms. Reister, for a nice brief about the legal implications with telemedicine. It is definitely an important issue. We have some questions that we'll leave them at the end of the session to discuss them. If you can stop sharing, if you can. Then our next speaker is, we'd like to have Professor Mohamed Hani. He's a professor of family medicine, College of Medicine, Medical Science, Arabian Gulf University. And also, he's a faculty member in Ain Shams University, Middle East and North Africa. He is a family medicine he has family medicine doctorate from the Suez Canal University in 2008, a joint master of health professional education master, Suez Canal University 2010, and fellow of the Foundation of Advancement of International Medical Education and Research Institute, Philadelphia, USA 2015. Has a number of international publications in medical education and family medicine. He will speak to us about telehealth innovations and health education and training. As we know, Arabian Gulf University had to go through a few innovations to continue education during the pandemic, and it's interesting to see how this experience is. And the floor is yours, Professor Mohammed. If you can unmute, please.
Assalamu alaikum wa rahmatullah. Thank you very much, Dr. Omar. I'm really glad to be here and to listen to all the great presentations by our colleagues. I hope that my presentation will also be useful to the audience. So the topic is about the telehealth innovations in medical education and training. We had a disruptive situation because of the COVID-19, and the College of Medicine and Medical Sciences at the Arabian Gulf University is a regional institution, and our students, as you all know, come from all Arabian Gulf countries. And this is why we needed to find a solution and to decide upon resuming the teaching activities and whether to continue our assessment. At the beginning of this, we were not sure about the duration of the lookup because of the COVID-19. So we needed to actually study things and come out with the right decisions. At the start, and as most of the medical universities around the world, faculty were asked to prepare presentations with audio added on to the presentations, and these presentations were uploaded to Moodle. But the engagement of students in education was missed in this using this method, and also the clinical teaching was another challenge. We started very early to include the tutorials, to resume our tutorials, our problem-based learning tutorials online, and then we started to think about the clinical teaching. So we started by evaluating the situation and consider our needs, our challenges, our resources, and what are the choices available. We needed a system, or we needed to resume the tutorials, as I've mentioned before. We needed to resume our resource sessions, labs, professional skills training, clinical teaching, and also to provide written assessment and clinical assessment to our students. All of these functions needed to be resumed properly with a proper level of engagement to students. So we started to find solutions. We started with online orientation, and we selected the following as our tools. We used Moodle as the central learning management system. We added Big Blue Button application to Moodle for the problem-based learning tutorials and also for the resource sessions. We used educational Zoom account for teleconferencing and distance education. And for the meetings, we also used Microsoft Teams for meetings and some of our teaching. Then the challenge was for the online testing. And this, we decided to use a software called ExamSoft, and I will come back to this in a few minutes. And we decided to use Zoom with breakout room function for our clinical assessment. And we used a lot of WhatsApp groups to facilitate the communication among all users of the teaching and assessment education. Then we started to think about alternative adaptations and innovations to make this possible. We started, as I've mentioned before, with the online problem-based learning tutorials. Then we resumed the online professional skills for the pre-clerkship and clerkship phase through also online. This is from our own professional skills center. And we started the online clinical teaching sessions with clinical scenarios and role plays in place. And we also had a decision to use a modified team-based learning also online. This slide shows the components of our team-based learning. We always start with a role play. Then we use Google Forms to send students the individual tests about the same topic that the role play was about. Then we sent them another link for the same question, the same set of questions, but for groups to solve together. And then we share with them the results of their quizzes and discuss among the students, among the small groups of the students, the results and how far they were as a group from the correct answers and responses. As you can see here in this graph, and these are the topics in family medicine, for example, and there is a significant difference in the scores of the groups compared to the scores of individuals. And this shows the value of working in teams, the value of thinking and working together for students. For the assessment, we use the exam software, as I've mentioned before, and we needed a software that is user-friendly, provides security, and can be used offline. And this is why we used the exam soft. We also wanted it to produce reports and analysis for the exam, and a dashboard like this one, which shows how many students uploaded the exam, downloaded and then uploaded the exam after solving it. It also gives you psychometrics analysis and item analysis for your questions, so you work on improving the quality of the questions. And also the exam soft allowed us to introduce high quality images and videos, which added to the value of the clinical exams, where we can, of the written exams, where we can assess high level or a different level of objectives. Then we moved to the clinical assessment. We used Zoom with breakout room functions. As you can see, we have here all the panels for the exams. This is 1A panel, and we started to assign examiners and the students to the panels and move the students around the panels just like a normal OSCE exam. This also needed assessor training and assessor orientation every morning before the exam. It required us to conduct multiple mock exams. It requires a lot of IT training, staff training, and IT support. This is a slide where we conduct exam preparation in the morning, in the exam, in the same day morning, with our IT staff, where we adjust for the sound, the video, and the slide sharing option. This slide shows how we introduce our students into a pre-exam room for ID checking by our administrative staff, and she has, as you can see, an Excel sheet that shows the pictures of the students, where she can check that these are the actual students, and she can also ask them to rotate the camera around the rooms to make sure that there is no this is an acceptable environment for conducting the exam. Then we introduce the students into the exam rooms or the panels one by one according to the pre-designed sheet. Here's the student with an exam, in the exam with an invigilator who's turning his camera off. And here we have the role player and the assessor in a family medicine station. Then the students are moved into a post-exam room where we have here our dear colleague, Dr. Mona Aliqat, Vice Dean for Clinical Affairs, taking the post-exam feedback from the students. This is our team organizing the flow with a department secretary, an invigilator, and another co-host who's assisting the host in moving students from one panel to the other. This process also required for us to prepare a lot of documents for the secretaries and the IT staff and the examiners and the instructions for students to make it clear and smooth as possible. And this represents the feedback from our students. This is an actual word cloud for our students. As you can see, the most prominent words are smooth, clear, organized. They like everything about the exam and even towards the ends of the exam. The challenges met the students were some online sessions. There's perceived monotony. They asked for more and more faculty interaction. Many students were apprehensive about the online assessment, but after conducting the online assessment, students were very satisfied at a very high level with the online assessment. Faculty faced some internet connectivity among some students. They were not satisfied about this. Few faculty encountered technical problems, and these technical problems were addressed by our e-learning team. Faculty found it challenging initially to evaluate students in an online medium, but after training and after conducting several mocks, it was possible. From this, and according to the theme of our symposium, what about the future of clinical teaching? I think that there will be more telemedicine in our future curriculums, in our future clinical teaching, and in our future clinical assessment. We will rely more on simulated virtual patients, and in this slide you can see a software that provides you with different options, and you proceed with your selection to the next step and the next step and the following step. And here is another example for a virtual program that gives you options to communicate, for example, with this couple who's facing a difficulty in conceiving or infertility, and it gives you choices, and you can select and proceed according to your choices. They will give you the response. So this will enhance your communication and consultation skills as a medical student or a medical practitioner. Professional skills teaching will also, I think it will evolve, and this image from an actual professional skills lab will also become a virtual application soon. The lessons learned from AGU experience that a wide range of clinical skills can be assessed through online assessment, of course, apart from physical examination skills. Mock exams are essential to guarantee success of online exams. Building faculty ownership through engagement in planning and implementation is very important. Cultural sensitivity during training and assessment is also important. Students enjoy working in teams, and more importantly, they learn from each other. This is something that we need to use. Live interaction with the students is crucial for better learning experience. More focus on communication skills and allowing more students to participate in role plays is recommended. Documentation, training, and clarity of all related processes are very important success factors for online clinical teaching and online assessment. This cannot be achieved without leadership support, leadership commitment, and collaborative teamwork from everybody, including our administrative staff, our heads of departments, our leaders in the school, and also our students. This is a collaborative work and cannot be achieved without full collaboration from everybody. Thank you very much, and looking forward for the next debate.
Thank you, Professor Mohammed. Very interesting talk. It's just, it is interesting how the innovation and the use of clinical tools or online tools have revolutionized this very difficult time for everybody. And as we said, this is telehealth, not only telemedicine or treating patients. It's also about dealing with our training and education, which is a big challenge for our students and important for their future and how they become our future doctors. And so that brings us up to the next debate we contemplated when planning this ethical symposium is, would we have a debate between clinicians in regards to how good or negative or positive telemedicine is, or going through the training? And we thought it would be lighter and more informative to highlight the student experiences. And today we have two very distinguished doctors, newly graduated doctors. Dr. Nalin Mathur, he's a graduate from RCSI, excellent student, and he has multiple researches and awards during his time in RCSI, and currently he is doing his internship in King Hamad Hospital. And also we have Dr. Fatma Nasser Al-Faiz. She's a newly graduate from AGU with an excellent GPA, a BSc Medical Science with Excellence with Honors, and has multiple awards, including the Mahara Government Academic Excellence Award and Hamdan bin Rashid Al Maktoum Award for Distinguished Student. So we will start the debate between the two. First of all, we will start with Dr. Nalin, and I would I would ask a question here and ask the same question later on for Dr. Fatma. How did your learning experience change after the pandemic? You ended up your medical schools, both of you guys, during the pandemic, and you're in the midst of your final months of training when all this happened. So I'll start with Dr. Nalin. Can you tell us about your learning experience change during the pandemic?
Yeah, thanks for having us, Dr. Omar Sharif. I hope you can hear me okay. I think the learning experience has actually been different for different stages of medical education. For example, for the first 3 years, non-clinical years, I actually don't think they'd be impacted too much, because before the pandemic, we actually used a lot of virtual education already. Online, there are a lot of excellent resources to study microbiology, pathology. You can find pretty much every surgery video on YouTube, and that's a great education source. We can also find clinical signs and symptoms. There's a lot of nice videos about pathological clinical heart sounds. And so we've been using these resources even before the pandemic. And I think the junior students will continue to use them alongside online lectures and pre-recorded lectures. I think their education should be not too significantly affected. But I think the students who are most affected would be the students in the 4th year, because those are the students who had to stop their rotations in the middle of the year, and they were not allowed to go to university, and they weren't allowed to go to the hospital either. And they need the clinical experience. Moreover, for them, they needed to go for clinical and research electives this summer break. They needed to go to the US, the UK, and Canada, and all those electives were canceled. And these electives, for them, are a very important part of their application process, for example, to the US. So I think now they'll be starting rotations, at least the RCSI students now, they're starting rotations next week, and with a much more compressed schedule. So I feel like they might not have as much clinical experience going into 5th year, and they might be impacted. For our batch in the 5th year, our graduating class, we already had finished our rotations. The main impact, as Professor Hani discussed, was on our exams. And it's interesting because I believe the AGU graduates recently had their exams, and the way they did it overcame some of the difficulties that we had when we did our exams in March and April. When we had our exams, our OSCE was moved earlier, so that we did it sooner, so that before the pandemic got worse and everything went into lockdown. We had a smaller OSCE so that we could comply with social distancing regulations. And our written exam was done online, our MCQ exam. We had an artificial intelligence software watching us throughout the whole exam through our camera. And so that software would flag us if we do any abnormal movements, like looking to the left too many times. And at the beginning of the exam, we have to show the computer the whole room, like below the table and everything as well. So that was a very interesting experience. And some students had difficulties with connectivity at that time. And it's interesting to see that now AGU managed to use a software which didn't require them to be online, which gets over that. So it looks like the virtual education system is advancing very quickly, which is very interesting.
All right, Dr. Nalin. So I guess you guys from a generation that uses the internet and like I would say like visual or artificial learning a lot, a lot of that on YouTube or in videos and stuff. And so it is a time that was maybe not that difficult, and you've been using some of the telehealth even before the pandemic. Dr. Fatma, tell us about your, so I guess Professor Hani and Dr. Mohammed did talk to us about the experience in the AGU, but we need to hear it from your students' perspective during this time. So tell us briefly about this thing, and then we'll go ahead and debate about positives and negatives of visual learning. Go ahead, Dr. Fatma.
Okay, so it's a pleasure for me to be part of this important webinar. I would like to thank you all, and I would like to thank AGU for this distinguishable experience of virtual learning. Actually, I'm a very visual person, and this new learning experience have had to add me a lot. We had the doctors having more chances. Sorry, I will just mute this.
Because even we have visual adhan here. Okay, so all right. Okay.
Okay, so
all right. Go ahead, Dr. Fatima.
okay, so the doctors have used a lot of various learning aids to make this experience more effective, and I had more chances to interact with the doctors, and it made it more one-to-one interaction. We actually started this virtual learning for 2 months. Actually, we started in May. 1 month I had surgery rotation left. We did 2 months as traditional learning, and I was left with only 2 months with surgery rotation and to finish the senior year. So we had the same scheduled lectures with the same quality of interaction with the virtual learning. I don't think that it had affected that much, but I think the doctors have used more various learning aids for us to have more effective learning experience. And as Dr. Nalin said, that we are have completed in the 5th year medicine, pediatrics, obs and gynae, and in the 6th year we have completed family, ENT, ophthalmo, psych rotation, so, and 2 months of surgery. So I don't think that this virtual learning have affected that much.
But again, but it would affect people who are maybe in the next few
in
months
year
who
5.
are doing some clinical rotation.
Yeah.
So that is a challenge that again we're gonna face in the next few months.
Yeah.
Dr. Nalin, tell me, like in 1 minute maybe or two, 2 positive things about the artificial learning and in your point of view.
Okay, so I think one of the main points for virtual learning is that in both AGU and RCSI, there are a lot of international students. For these students, it can be very expensive to be in Bahrain alone and pay for transport to hospital, to the university, rent a car, get accommodation. All these costs go away with virtual learning. I think students these days can even stay in Canada or stay in Arabian countries and study from home, at least for the first 3-year students. They can save a lot of money with virtual education. And this can be a major factor because a lot of students take loans for their education, which they have to pay off later. So any decrease in that burden can be very helpful. And the second point is that virtual medicine helps students connect online through different platforms like Facebook, Twitter, Reddit, Instagram, while also being mindful of patient confidentiality, as Dr. Lena had discussed. This is a great opportunity for students and doctors around the world to share their experience. For example, on my Instagram, I have my friends, but I also have medical accounts that I've added. So while I scroll during my break, I come across surgeries and little explanations with the memory devices that help me remember and also motivate me to keep studying. And I think this is a big tool that a lot of students use. In terms of the COVID pandemic, the entire genome was published and open to the public in just 3 days. Whereas if you go back to the 2003 SARS pandemic, I think it took like 3 months before all the information was out there. So we've come a long way, and virtual medicine has made education as well has made a big difference in our learning in a positive way.
Dr. Fatima, you counter and like give me 2 negative things that you think from all this.
Okay, so the one important negative is that we lack hands-on training, which is a very important thing that Dr. Mohamed Hani has already encountered. The second thing is the internet connection. Many times we are dependent on the internet connection. We have lost the live interaction with the doctors. Already the lectures were recorded. We can visit them again, but the live interaction and the questions that are going to encounter with the doctor are being missed. The third thing is the self-control. Now, we are not depending on the university, where the university is dependent on us, and we are dependent on ourselves to sit and attend the lectures and study on ourselves. So self-control is a positive and a negative. We are maturing our self-control, but at the same time, we are dependent on ourselves. So I believe that anyone who wants to learn will have time to learn and will find a way to do so, but it's also a negative thing.
All right. How about now? Give me some positive things.
Okay.
From your point of view?
Me or Dr. Nalin?
From you.
Okay.
Dr. Nalin told us the positive things, so we'll get back to him, see what negative is about it. But from your point of view, what is something positive about it?
Okay. As the doctor said that we have overcome the geographical barriers. In the past, we have in the traditional lectures, the students attending the lecture are out of 80 students in the rotation, only 20 students are attending the lecture in the hall. Now with the Zoom meeting, all the students, like nearly 80 of the students are attending in one lecture, or about 50 to 80. So we have overcome this. Second thing we have overcome is that the quality of the slides. So everyone can see the slides. There are no complaints about that. Second thing, that we are more concentrated with the doctors and we have more interaction with the doctor. There is no distraction, students coming in the hall, students going out. The lectures are recorded, as I said, and we can visit them anytime. Time management, we can manage our time, and as I said, self-control, I perceive it as an advantage, but it's a disadvantage for some students. I have learned to control myself and be more responsible about attending lectures and studying by myself. So these are the advantages.
I guess, you know, the lectures, you say that you don't interact with people about it, but again, it's much easier to attend a lecture like if you are doing it virtually. Like look at today's like a symposium, we have like more than 450 attendees and coming in from their comfort at home and can attend it and watch the lectures very easily. But at the same time, you're staying at home and say like, is that really a good thing that you're staying home? Are you going to be simulated fine or not? What do you think, Dr. Nalin? What is negative about that? If you're staying at home, do you think that is better to study if you are at home and doing it at your own pace and time? Or is it more distracting? Like you can go ahead and you can play your video games or something, don't you? Or do something different than studying while being in the library might be something better or more committing. What do you think, Dr. Nalin?
I'm sure some students flip between the two, playing video games, going back to the lecture and back and forth. And we talked about how there's a lot of resources online. We've talked about how lectures, there's more attendance and things are going well. But I think ultimately at the end of the day, even though online learning is very efficient, we can't apply the knowledge that we learn clinically until we go and see the patients. In hospital, we have patients with multiple coexisting issues, polypharmacy, social issues, and we have to learn to solve these things and dealing with these complex real-life problems. And the other issue that I wanted to focus on is the psychological aspect of medical education. Medicine in itself is a social activity, I think. We need to interact with each other's professors, our colleagues, and patients so that we know in the future how we can provide care and comfort to these real and dynamic people that we're treating. Socializing is also very important for our own mental health and our support system, which is critical for us because we are in such an emotionally demanding field. And as doctors, we derive strength from camaraderie. It feels for us, for me in particular, it feels so strange that I don't get to see other interns in the hospitals. We don't sit in the cafeteria and discuss the cases that we've been going through. All the little emotional things that happen throughout the day, we don't get a chance to discuss these things. We suddenly lost touch with such an important support system that we've been through for 5-6 years of education. And that's during such a big transition in our lives, going from students to doctors. And virtual meetings and learnings can't change that. So the psychological aspect, I think, is also big.
Absolutely, Dr. Nalin. You know, it has been a hard time for everybody. I guess it gets us to appreciate what we had before and go forward and learn from all this, what's going on, either from patient interaction or from learning. Thanks a lot to both of you, and I wish you all the best for everything. And it's been a very interesting debate. I wish we had more time for more debate and more points and get more interaction. Thanks a lot for all this. I would advise the participants to get your link in the chat to finish the survey afterwards, and would appreciate doing that. Any questions, we can go through Q&A and put them in. We'll end up the session right now with the Q&A. We'll spend some time on that, and I have a few questions from the audience. There is a question from Dr. Dalal for Mr. Isa. if we have a documentation of advice on WhatsApp telling a patient to go to the ER, but we did not document that in the medical file, and patient deteriorated and has a lawsuit against us, is the WhatsApp message acceptable as an evidence,
Dr.
or it's not
I
going to be?
apologize. Could you say that again? Because
So a patient texts me on WhatsApp and tells me something. I tell him go to the ER. It is documented in the WhatsApp message, but I did not document that in HOPE system, in the medical record.
Yes.
Is the doctor liable if the patient goes and sues himself, he did not give me a good advice, or is the WhatsApp evidence enough for that?
WhatsApp is evidence, actually. It is.
All right.
That will hold the doctor liable.
All right. All right. So this is great because we do a lot of what we call WhatsApp medicine nowadays, and it is good that this is an evidence that can be used in a legal way.
Yes.
From Dr. Khadija, also for Mr. Isa, do you need to attend a specific course before practicing telemedicine? And this, I think, was touch based on Dr. Dalal. She did one herself. But is that going to be a prerequisite or be used for an licensing base or something like that?
The question is, who can issue those courses? Like, who would be the one issuing those courses? But from a legal perspective, yes, it is advisable, because at the end, we do try to have some value, dependency, and credibility in that process, which is telemedicine. But we need to lower as much as we can the malpractice cases, misdiagnosis, because that is the main issue. So going back to the question, who can issue those practices, or as we say, approval stages? Currently, the NHRA has released that you can provide telemedicine. Those are the services. But if anything goes wrong, you are liable as the traditional practice. There's like a core in between that is not clarified. That's what I believe.
I see. Dr. Hisham, Dr. Mohammed, Professor, so what do you think in regards to the different tools that have been used, like Zoom and the other ones and WhatsApp? So which one do you like stands out there as a good tool that might use on? And I guess you talked about this issue in general, but what is your maybe personal preference, and maybe that showed some good student reactions?
Yeah, I'm a big fan of Zoom. I think they should give me some kind of discounts for or some kind of percentage for using promoting their product. Actually, it's very simple. It requires not so high quality of connectivity, and the breakout room function is marvelous. It allows you to put participants together into breakout rooms, and they can see each other with video. And this is a very important feature that we've used in small group teaching and also in the exams.
And then another question for you, Professor Mohammed, is like, do you think the loss of hands-on is going to be an issue for newly graduated doctors? And an argument would be like, if you're a final year student, you are going to be a doctor in a few months, and you are going to deal with COVID patients. So how is that going to affect them? And do you think we have to be more advocates of having more hands-on, even with taking some risks of getting an infection? End of the day, a doctor will take some risk. So what's your opinion about that?
True, I think this will be determined during the next few months. We will see about this. For our seniors like Fatma, we have already graduated. They had only surgery, family medicine, and psychiatry rotations for the rest of the year. So they have been through the internal medicine, pediatrics, with all the essential physical examination skills already covered. So we had no problem deciding on graduating them and using virtual teaching and virtual assessment for this. But for other groups of students, we need to rethink about this. Maybe we organize the professional skills and add this more, and of course include patient encounters, which cannot be. We cannot graduate doctors without being able to physically examine real patients.
A question from Dr. Hisham to the students. How about the students losing the motivation when seeing others studying and reading, or having side talks about one of the topics? Did our students at RCSI and AGU feel a drawback? I guess we did talk about this a little bit. I don't know, Dr. Fatma, want to tell us about your experience, and Dr. Nalin did talk to us a little bit about it. So what do you think?
Well, I am a library person. I don't study at home. In the past years, I don't study at home at all. I only study at the library of EDU. So I have study mates in the library of EDU. So I have lost my study mates. I have lost the place of studying. I have to assign another study place at home. I have to assign study mates, which are virtual study mates, which are, you can find them at YouTube. There are people who are studying online, live, 6 hours, 12 hours. You can choose the video and you can study with them. So I have replaced my study mates. Not that much replacement, but it had made an effect of studying for me. So
I guess last question for Mr. Almuradi. And if there are going to be video calls or phone calls recorded, are they recorded first of all? And how is the privacy of patient protected in this situation? And should we have more consenting on that regard?
So is he asking, should we record?
Should we record? And if we record, how is that privacy is protected, and how legal is that going to be?
In terms of recording, you should not record. That's first of all. But however, in terms, you are obliged to store them. You have to check if the data is encrypted properly in terms of IT perspective. But in terms of recording, you're not allowed to record.
All right. I guess there are some more questions, but the time is up, and it's been a very interesting symposium. I would leave the floor. Thank you for all the Professor Mohammed, Mr. Isa, Dr. Fatma, and Dr. Nalin for your time. And I'll leave the floor for Dr. Dalal for closing remarks. Thank you, everybody.
Thank you, Dr. Umar. Thanks to Dr. Nalin, Dr. Fatima, Professor Mohammed, and Mr. Isa. Thank you all. So I asked all the behind-the-scenes staff to show us their videos. At the closing of this symposium, I would like to express my sincere appreciation to all of you, starting from His Excellency Sheikh Mohammed for joining us today and giving us some of his very, very valuable time. We could not have done this without the support we get from the higher administration, our CEO, Dr. Sheikh Salman Al Khalifa, Dr. Dalal Al Hassan, who was the backup for me. When I said, should we do it? Should we do it? She said, go ahead and do it. And she did all the needed support. And of course, thanks to all our speakers, the session chairs. Thank you to our PR department, Mr. Lieutenant Ahmed Tamimi, to Zainab, to Ziad. Justin is with us today. Hi, Justin, if you can see me. Thanks to Koshi for all the artwork and Rana for all the needed translations. And our superstars, thank you to Ms. Luma, Head of Research at KTUH. She has been wonderful helping and guiding us through this. Thank you to Ms. Reshma. Although she's not in Bahrain, she's with us. She was instrumental to every step to make this a success. Thank you, Stephanie. You are a superstar today hosting this event. Thank you so much for Dr. Ahmed and Dr. Dua, who are our wonderful registrars, senior registrars, who are great in everything they do. And they were chasing you all to keep your names, first name and last name. And they did a great job monitoring the chats for us today. So for all our attendees for spending this Saturday morning with us, thank you. I hope we sparked something to motivate discussion, something to motivate NHRA to think a little bit more about that, to motivate doctors, nurses, all of us to think a little bit more. This is a great start, but we need to regulate it better. Thank you and have a wonderful day. Ma salam.